Kazakhstan has passed the COVID-19 peak, Health Minister Alexei Tsoy stated on Monday. The epidemiological situation has improved in 6 regions and the country's capital as a result of the second nationwide lockdown and a better approach to responding to the pandemic. The Kazakh authorities have acknowledged that the magnitude of the threat was previously underestimated. The coronavirus outbreak has revealed the systemic errors and pushed the government to start implementing structural reforms. What is the effective strategy to combat COVID-19? To discuss this, public health consultant Ali Nurgozhaev joins me today. Ali, welcome. In your articles and social media posts, you often write about the shortcomings in the healthcare system in Kazakhstan. What were some of the major problems in our public health system that the pandemic revealed?
Hello, Lyazzat. There was a number of systemic problems, primarily in the epidemiological response service, which was the principal sector that responded to the pandemic. One of the major challenges was the worn-out infrastructure. For example, in Nur-Sultan, some of the buildings of the infectious diseases hospitals were built in the 70s and 80s, and they are in quite a depressing condition. Another challenge was the provision of oxygen. There was a shortage of it in the multi-purpose and infectious diseases hospitals everywhere. The norms of sanitary and epidemiological standards we are using are also outdated. During the merger of hospitals, which has been the trend of the past 3-4 years, these sanitary and epidemiological standards should have been updated and undergone a holistic reform, but we have only united them on the paper. For example, in Nur-Sultan, the infectious diseases hospital was merged with the oncology center. No doctor, no healthcare manager can give you a rational explanation of why this has been done. This should have never been done. So the infectious diseases response service was outdated. On top of it, due to the merger, the accountability system has been destroyed, as was the readiness of the system to respond to the pandemic. Another problem we were faced with was the shortage of the personal protective equipment. The personal protective equipment for doctors and physicians has always been the last item on the menu of priorities. I worked on the development of tariffs, and I know that funds were never explicitly included in the tariffs for the personal protective equipment. And so they were always purchased for the leftover funds. Most of the infectious diseases hospitals did not have even enough personal protective equipment sets. We did not have enough domestic manufacturing of those. Then when the pandemic happened, the demand for all these things increased worldwide, and so we were unable to secure these items in the necessary amount.
Мы его не смогли обеспечить, потому что другие страны в это время тоже пытались получить объемы.
The last thing I want to add is the tariffs. Our tariffs for infectious diseases are very simplified. If for other non-communicable diseases our tariff-based system has clinical cost groups, and this is a fairly advanced system that reflects the real costs of providing care for patients with different diagnoses. But for infectious diseases, unfortunately, the tariff is the same for all infectious diseases, regardless of the cost of providing care. This also demotivates the infectious disease centers as a whole.
What do you think were some of the reasons for such decisions on the part of the government and the Ministry of Health, decisions like the merger of infectious diseases hospital and oncology center, or lack of the tariffs for the infectious diseases?
Firstly, this is of course a question to whoever made this decision. Secondly, it's hard to say. You know, we probably got used to treating infectious diseases as a non-priority. There is a concept called the epidemiological transition. It happened between the 1960s and 1980s, when the non-infectious diseases, circulatory system diseases, chronic conditions began to prevail over the infectious pathologies in the developed countries. African countries still have epidemiological challenges, and the global donors are helping them deal with those, but in Kazakhstan this transition has already taken place. But as we can see from this pandemic, this was a global error. The countries underestimated the risks of the epidemics, when in fact, viral diseases pose a greater threat than we had expected. So our situation is similar to those in other countries, where we all believed that we are relatively safe from the pandemics. We also had a problem with the sanitary epidemiological services. They became a prestigious place to work instead of being an effective service. They play a key role in responding to the epidemic. All of this has led to the unfortunate situation we are in.
In the spring, the nationwide lockdown that lasted for about 2 months seemed to have been the perfect opportunity for the healthcare management systems to mobilize and prepare to respond to the crisis. But in June, we witnessed the delays in distribution of humanitarian aid, shortage of certain drugs in pharmacies, difficulties in procurement of medicines and medical equipment. How do you explain the slowed response to the situation?
Здесь мы давали уже рекомендации в начале эпидемии.
We gave our recommendations at the very beginning of the epidemic at the end of March. But these recommendations were taken into account with a delay of 1.5 to 2 months, when the situation itself forced the healthcare system to adapt and react. We saw how this has led to the changes in the healthcare ministry. First and foremost, the former health minister has been replaced with a new one. I will not comment on the former minister, but I can say that the health minister is very responsive now. I personally had 2 requests of social nature, and the Ministry of Health reacted at the highest level. So I can say the authorities are responsive to the expert community. But I'm afraid it's a bit too late. I wish they had been responsive earlier. Regarding the slow reaction of the government to the development of the situation, well, I think firstly there had been problems with interagency cooperation, and secondly, there was most likely a lack of understanding of how serious this pandemic was. It all seemed fine one day, and things were turned upside down the next day. So the situation has evolved way far ahead. And the most important thing is that the healthcare system is an abstraction. There are concrete people behind the system. If these people set specific tasks and then follow up on the implementation of these assignments, check the information, make cross-checks of the reports and monitor the field work, then everything will be fine. So it seems like there may have been problems in setting the clear tasks and controlling their implementation.
Здесь, мне кажется, была проблема в постановке задач и их контроле.
Ali, как вы уже сказали, с некоторых пор заметны решительные шаги. Over the past month, we have seen that the government is taking decisive steps. There has been a change in leadership in Health Ministry and the SK Pharmacy. Has there been any improvement in the organization of medical care for the population?
Yes, indeed. I see improvements in how the medical care is organized. In particular, this concerns the coronavirus treatment protocol, which has been significantly improved. And secondly, it is the introduction of new forms of medical care. In particular, they made day hospitals and mobile teams available. These had not been mobilized for fighting the coronavirus infection. The ministry is really improving the forms of rendering care and increasing its availability. That is exactly what is needed at the moment. But unfortunately, it may already be quite late now. We can say that the new team has taken charge of the healthcare system and our population in the 4th stage of cancer, so to speak. This is an analogy. It will be a miracle if this situation is improved.
You mentioned the COVID-19 treatment protocol. We know that the protocols are rather lengthy documents. It is hard to imagine that the medical staff, medical workers would be able to read the 100 pages of the protocol periodically with which they are published, especially given the workload. Considering that a number of viral pneumonia cases will be included in the general statistics of COVID-19, the protocol, as well as the classification of the disease, will again be updated and sent to hospitals for use. How can the studying of the protocols and the classification of COVID-19 be made easier and facilitated for the healthcare professionals?
Indeed, reading 100 and more pages of complex terminology every 2 weeks is a difficult task. There are several solutions that we have already recommended to the ministry, and as far as I know, they will be adopted in the next edition of the protocol. First, there needs to be a control of the versions of the protocol that are in use. For that, in the beginning of the new version, there needs to be a highlighted list of the new changes. If the staff have read the protocol once and understood it well, then the next time they simply study the changes and don't have to read the 100 pages all over again. The second point about the protocol is simply formatting. That is something most clinicians don't have the ability and skills to do themselves. The task of the clinicians and scientists who write the protocol is to write the correct text. But formatting the document and making it more user-friendly is another task. The Health Ministry has certain departments and specialists who can do this and can facilitate the learning of the new protocol for the practitioners. Because when a person starts reading the document and does not understand how to navigate the content and headings, then there is a problem.
Now I know that this problem is starting to be addressed. Further, I think that some of the information must be presented schematically and visually, with the help of diagrams. Not every part in a 120-page document is equally important. There are sections like extracorporeal membrane oxygenation, ventilation, and some highly specialized sections that only the appropriate specialists should read. The parts necessary for reading for all health workers can be outlined in a more schematic manner, and then doctors will simply see if they are following the scheme correctly and what section to switch to next. Moreover, there is a language barrier. If we want to ensure the effective use of the protocol by the medical workers, we need to publish it in the Kazakh language as well. We live in Kazakhstan.
So the COVID treatment protocol is not available in Kazakh.
As far as I know, it is not yet available in the Kazakh language.
This is upsetting. The number of COVID-19 cases is growing, as is the pressure on the public health system. How do you estimate the real need for beds, drugs, and staff in provisional and infectious diseases hospitals at the moment?
There are things that can and cannot be calculated. We can calculate the real need for personal protective equipment because they are used by doctors. That is, we take the number of beds or the number of doctors, the frequency of the personal protective equipment use, the duration of their use, and that's how we can calculate the country-wide demand. We can do this with the infusion pumps as well. But it's hard to predict the actual need for beds or drugs because this depends on the course of the epidemic in Kazakhstan. We know little about the global course of the epidemic because, unfortunately, different government agencies give different estimates. Some predict an overall of 1 million cases. Some say the number is already around 2 million. The combined number of pneumonia and COVID cases is around 200,000 or so. So it is impossible to estimate the demand in beds at this stage. But there should be a commitment to a full-scale readiness. The drugs have an expiration date. We're now in a state of war against COVID, so we need to stock up the resources without worrying about the budget efficiency at the moment. We will use what's left next year or in 2 years.
Is the proper access to planned care and emergency care for non-COVID cases maintained during the pandemic?
We have a problem here. As one competent clinician and oncohematologist Irina Pivovarova says, the whole country has already become provisional. Now it's hard to say who is ill and who isn't, because many of us may be infected but are asymptomatic. So we must maintain the highest access to the routine medical care. The Ministry of Health has already begun working on this. I have inquired the authorities about the resumption of hospitalization for autoimmune diseases, and indeed, within a week, my request has been satisfied, and these hospitals have resumed work. This is very important. We cannot allow those critically ill to miss hospitalization. These are the cases associated with strokes, heart attacks, cancer, and others. Access to this type of care has been reduced during the peak of the pandemic. If we don't restore the access to healthcare by autumn, then by winter we will receive higher mortality and disability numbers and the overall irreversible decrease in the quality of people's lives. These may not be immediately reflected in the general statistics, but the health of the population will be in great danger.
Здоровье населения сильно может пострадать.
Let's talk about the new compulsory social medical insurance system in Kazakhstan. Before April 1st, all citizens were considered insured. In April, an exemption on monthly health insurance premiums was introduced. This exemption was terminated on the 1st of July. Is it correct to say that the citizens who are not insured do not have access to free hospital and primary care? If this so, how ethical is this decision during the pandemic?
You know, first of all, you need to remember that compulsory social medical insurance is not the entire healthcare system. There is a guaranteed medical insurance package and a package of compulsory medical social insurance. And the guaranteed medical insurance package, in any case, remains available to everyone. Access can be reduced to the social medical insurance package for those who cannot afford paying the monthly premiums at the moment. And that is wrong. The country declared an emergency state in spring and paid the jobless 42,500 tenge to help cope with the crisis. These payments have been stopped now. People's incomes have significantly been reduced. Many industries are stalling. The small businesses are dying. People are losing jobs. Accordingly, now is not the time to collect insurance premiums.
Ali, an important question that interests many is the outbreak of viral pneumonia cases. Unfortunately, in a number of cases of viral pneumonia, the PCR tests were negative, so these cases were not classified as COVID-19. These cases will now be combined into the general statistics of COVID-19. Why were the test results negative in these cases?
I am glad that in the end the ministry decided to combine the numbers and admit the mistake in the classification. There are several factors that played into the picture here. Firstly, the very accuracy of the PCR tests, that is a margin of error of around 20 to 30%. The second factor is whether the laboratories were used to their full capacity, including the laminar flow cabinets, ventilation systems, and other measures that ensure the purity of the test. The third point is the technique of taking the test. The swab stick must go deep in the nose. It must have a special material on the tip. We cannot be sure that this material was correctly stored everywhere. We cannot be sure that the swab was collected correctly everywhere. Therefore, all these factors contribute to the 10, 20, 30% error margin, and as a result, we get the PCR test results that are negative. But of course, not accounting these cases of pneumonia as COVID was incorrect.
The government recently adopted a new plan to protect the life and health of Kazakhstan's population amid the pandemic. This plan includes some of your recommendations. Please tell us about the new document.
I think that the plan has outlined the measures that need to be taken and areas that need to be mobilized. This plan should have been compiled and issued much earlier, because previously we didn't have a unified, comprehensive document that presents all these steps aimed to respond to the pandemic. Now this plan must be regularly updated. The situation changes every week. Corrections should be made accordingly. The most important idea that is reflected in the plan is that now we have realized that we will have to live with COVID-19 for a period of time, accept the reality and take a systematic approach to what resources we employ during this crisis. The plan must be provided with resources, otherwise it cannot be executed. And of course, the implementation on the ground must be well supervised.
And who should ensure the execution?
This should be an interdepartmental work of the Ministry of Health, the local health departments, and other government agencies whose work is related to ensuring the health and well-being of the people. Secondly, interdepartmental communication must be improved. I am not sure that, at the moment, it is well established. The media reports make it look like the Ministry of Health is the only responsible entity. It is also important to understand that the plan is the first operational step. It will be updated, and in the fall we should see the next version and so on. The important thing is that strategic document must also be regularly updated. We have the 2025 Healthcare Development Program. It absolutely does not reflect the response to the pandemic, so it needs to be revised completely. I hope this pandemic forces the healthcare system to improve rapidly.
Ali, thank you for an insightful discussion.
Thank you.